day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It's my pleasure to welcome you today to our first webinar in the series on value-based payments. This webinar is also a joint offering with eHealth Initiative, or eHealth. Before we begin, I would like to mention a few logistical items. You'll be able to download a copy of today's presentation from the CAQH.org website in the next 24 hours. To do so, navigate to the Core pull-down menu at the top of the CAQH.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation, as well as the recording, will be found under the listing for today's webinar. We will also send you the slides and the recording tomorrow, so you'll have easy access to the information we present today. We will save time at the end of today's program to respond to your questions. You're encouraged to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. We do ask that when you submit your question, please identify the type of organization you're with so we can give you a more applicable response. Our session today will start with an overview of CAQH Core's work on value-based purchasing, followed by an overview of eHealth's work in general, as well as in VBP. And then we will move on to our featured presentation, which is titled Value-Based Care for Success in Value-Based Payment. I have already highlighted the items on this slide, so we can go on to the next slide. I'd like to thank our guest speakers for joining us today. They are listed on this slide. I will properly introduce our featured speaker, Dr. Stephen Waldron from the American Academy of Family Physicians, later on in the program. We are really happy to have you here today, Dr. Waldron. So let's get started with today's program, which is an overview of CAQH Core's role and work on VBP from CAQH Core Director, Erin Weber. Erin?
Thanks, Jessica, and welcome to everyone joining us today. Before we get into the meat of the presentation, I wanted to share a quick overview of some of the work that CAQH Core is doing in the area of value-based payments. On slide 7, you'll see the mission and vision of CAQH. Our vision is really to be an industry-wide facilitator of trusted, simple, and sustainable healthcare data exchange that evolves and aligns to meet market needs. We really have an integrated model that is focused not only on developing operating rules and other industry solutions that accelerate interoperability and address administrative challenges, but we also offer certification, education and outreach, promotion of adoption, and maintenance of those operating rules. We are governed by a multi-stakeholder board with representation from both providers and health plans, and we were named by the Secretary of Health and Human Services as the National Operating Rule Author for several transactions over the past few years. A little bit of history on why CORE was started was that the original vision of HIPAA back in the early 2000s was that providers would be able to automate their systems as they were doing things like eligibility, claims, and EFT payments with health plans. But those initial HIPAA transactions weren't quite uniform enough that systems were being automated. So the concept of operating rules, which is used in other industries like banking, was brought into the healthcare arena to help streamline the use and standardize the use of these transactions. And so today there are 4 sets of operating rules available for industry implementation. On slide 8, you'll see our focus to date has really been on those standards and operating rules for the fee-for-service models. But as the industry begins to transition toward value-based care and value-based payments, we're looking into how CORE can better support this transition and maybe address some of the challenges that we saw with the earlier fee-for-service transactions earlier in the game. We know that value-based care is increasing in the market. 30 to 50% of providers are engaged in VBP, and we expect that number to increase over the next few years. The transition to VBP, though, has not been without challenges, and we've had a lot of conversations across the industry about what improvements can be made in operational capabilities to ensure success of VBP. There's a lot of proprietary systems and processes being implemented with VBP, and that has addressed some operational variation, which makes it difficult for providers to manage and automate value-based care and purchasing scenarios. Because of this transition, the quick transition, these operational challenges can be a real burden to providers, and the need for uniform and efficient operational systems will be very critical for VBP to become more mainstream. On the next slide, this is why I think CAQH is well positioned to support value-based payment operations. We have, in our work with the fee-for-service area, really become a change agent. We have over 130 organizations that come together to participate in CORE, including health plans, government agencies, standards organizations, and we really have the expertise to bring together the industry to find ways to harmonize practices so that they reduce the administrative burden across the industry. We have seen significant improvements in fee-for-service operations and significant ROI from the operating rules, and currently more than 76% of the commercially insured and 44% of publicly insured individuals are covered by CORE certified health plans that are operating with the rules in place. So I want to talk very quickly about the work we've done in VBP to date. We have, our board of directors made a decision to include value-based payments as part of our work effort a little over a year ago. And since then, we've conducted extensive research on opportunities through interviews, surveys with our participants, and starting to do more webinars like this to build out industry awareness and expertise. We are identifying opportunity areas for improving operational efficiencies in VBP, and we plan to launch an action group early next year to start looking at some of those issues and identifying recommendations and strategies to ensure consistency across the industry. One of the areas that the report will focus on is data quality improvement and standardization on slide 11. One of the areas that came up as a high interest in the research that we did was the challenges of poor data quality, both on the health plan and provider side. High quality data is critical for VBP. Specifically, we noted challenges with provider data, and also that VBP models will require new data elements. So use of the HIPAA transactions may change due to importance of information such as encounters. Also, the role of social determinants of health will play into factors as well. So with that, you know, if you're interested in getting more involved in the work that we're doing, you can always email us at core@caqh.org. And I'm going to turn it over to Jen CAQH, the CEO of eHealth, to talk a little bit about the work that eHealth is doing. She has served as CEO since 2009, providing leadership for all the research, education, and advocacy components of eHealth. Jen?
Thank you so much, Erin, and I'm really interested in the work that you guys are going to be doing over the next 12 months. A lot of our work dovetails, so it's really a pleasure to be here with you today. And I hope this is the first of many sessions because we have a great interest in the value-based care market and where we're headed with that. So to get started here, so for those of you who aren't familiar, I'm Jen CAQH. I'm the CEO of the eHealth Initiative. We've been around for about 17 years. If I could get the next slide, I'm having a problem here getting to the next slide. Could I get the next slide? Could I get some help with the slides? Thanks. Great, thank you. Thank you. So eHealth Initiative, we primarily do research, education, advocacy, and our whole mission is to figure out how can we tap into the executives across the spectrum of healthcare, gather information from them through research, surveys, interviews, roundtables. We do a lot of convening with executives at the top level, and then put all that information into outputs, reports, guidance, education, and series like this that we have here today to really try to help move the industry forward. If I could get the next slide. Thank you. And we're focused around 4 different areas: interoperability, data access and privacy, patient and provider technology adoption, and data analytics. And really what we try to do is bring together these executives and identify best practices. There's a lot of stuff going on around the nation in kind of little nooks and crannies in areas that you don't think about. And we really feel like it's our role to identify where those things are happening, point them out, and share them with the rest of the industry as well. So that's really what we're focused on. Next slide. And we take all of this information and we put it into our eHealth Resource Center. And this is available to you right now. In fact, I strongly encourage you to take a look. Go to ehidc.org/resources, and you can see all of the materials and reports that have been gathered, not just from us, but from our constituency, from groups like CAQH, from all of our member organizations across the spectrum. And we gather all of this information and make it all available to you free of charge. We are a nonprofit, so it's all available there for you right now online. The other great thing about the eHealth Resource Center is that we want to hear from you. We want you to upload your case studies, your reports, your blogs, your opinions, your feelings on where this is all going, and you are free to do that. It's very easy to do. You just click on the green button there, and you can upload any work that your company is doing. We will accept materials from nonprofits. We'll accept materials from for-profits. This is a great way to get visibility on work that you might be doing. And this is really one place that we go when we're looking for best practices and things to point out, when we're looking for experts and leaders in the field. So this is the best way to get noticed, I think, is to really upload your materials into our resource center right now. And this, again, is a forum for sharing. It's a place where you can go share information about what you're doing or just learn about what other people are doing in the industry. And it's really a great, I think, an opportunity for EHI and also for CAQH to work together. And next slide. So one thing that I did want to mention is a new initiative that we've been working on, not necessarily new, we've been working on this for 6 months right now, but the Electronic Medication Adherence Collaborative. And this is really all around trying to identify, it has to do with value-based care, it has to do with medication, it has to do with patient safety. We're really trying to identify best practices around different analytical and behavioral approaches related to medication. And as I think most of us know, this is the biggest cost, really cost suck in terms of the healthcare industry. This is where a lot of the costs are and where a lot of costs can be saved. And it also has a tremendous impact on quality of care and treatment. So we've seen this across the board. So we are looking for individuals who have case studies, examples, stories, reports, expertise, or any interest really in looking at medication adherence right now and innovation. So if that is something that you're interested in, I really strongly encourage you to get in touch with Claudia Ellison, whose email is right there. And one more slide to go. And finally, I just want to let everybody know we have an executive summit that's going to be taking place February 7th and 8th in Washington, D.C. At Top of the Hill. Many of you are probably familiar with our 2020 roadmap, which was published about 3 years ago next month. And this document really laid out the priorities and strategies for the entire healthcare IT community. And it's really time to refresh that document and rethink our priorities in light of the new administration, in light of value-based care. And I think the value-based care piece is really the most important. So things that you're going to hear today from Steve Waldron, from Aaron and Jessica and others really are going to impact what the priorities are for the private sector moving forward. So it's time to take a second look at that. So I'd like to encourage all of you who are executives to please join us for that meeting in Washington, D.C. We will be bringing together executives to identify what are the most important things we need to be working on in terms of policy, in terms of interoperability, in terms of incentives, patient engagement, innovation, technology, et cetera. And this is going to be a really important meeting in time. So I'd like to invite you to join us that day. It's going to be very important. And if you want more information on that, you can go to our website as well, ehidc.org. And that's there for you. And then as I turn it back over to Erin and Jessica, I just want to again say thank you and stress how important the Value-Based Care Initiative is to us as a whole. We've had a number of educational conferences, webinars, and roundtables over the last several months, really focused on how this is changing, how we collect data, how we look at data, how we analyze data, how we report data. It's really impacting and transforming the entire healthcare industry, so it's very important right now. So I share their interest in it, and we look forward to working with everybody on this. So I'll turn it back over to you, ladies.
Thank you so much, Jennifer. We really value your collaboration with us in this and many other efforts. So I would like to take a pause and do a quick polling question to get a feel from our audience and what data quality challenges they may be experiencing. So let's start the poll. You can see the question is, what data quality challenges have you experienced in your organization? This is a check all that apply. So let's take a few minutes. So are the challenges the data itself? Is it incorrect? Is it in the wrong field? Is it a technical inability to share or manipulate the data when you need it to do what you need to do? Is it a problem with semantics, definitions? Is it a timeliness problem? And then is it a lack of analytics skills, either you or your department or your organization? So let's give it 5 more seconds and then we'll show the results. Okay, so let's close the poll and share the results. So there are definitely some categories here that seem to be bigger challenges for our audience, and I think this is interesting. Dr. Waldron, it'll be interesting from your perspective whether this is in line with what you anticipated or not. So the top candidates for challenges are the data, the quality of data itself, and then the timeliness of the data, followed by semantic issues. So thank you very much for sharing this information with us. And with that, I'd like to introduce Dr. Stephen E. Waldron, who is the director at the American Academy of Family Physicians Alliance for eHealth Innovation. Dr. Waldron joined the AAFP in May 2004 because of his knowledge of design and management of health information systems, computer science, and medical informatics. Prior to joining the AAFP, Dr. Waldron was a National Library of Medicine Medical Informatics postdoctoral fellow at the University of Missouri. Dr. Waldron is also a residency-trained family physician, and we would like to welcome Dr. Waldron. Please begin when you're ready.
Well, thank you very much. It's a pleasure to come and chat with you guys today. And unfortunately, I don't think that poll was too surprising for me. I think there are a lot of challenges with data quality and timeliness and just accuracy of the data are definitely the things that I hear a lot in the industry. So what I wanted today, though, is to talk a little bit. So you heard from EHI, focused on from an executive perspective and kind of the why and what are the policy implications and policy issues around value-based payment. And then with CORE, they're kind of waist deep into, the how you get this accomplished. What I wanted to do a little bit is kind of be in the middle there and talk about the what, and do it kind of from a provider or practice perspective. So I'm going to talk a little bit about kind of the value-based care. What are the data needs to be able to be successful in that so that you can be successful in value-based payment. So on the next slide, we'll talk a little bit about kind of what we're going to talk about today. And I always want to give you kind of a brief overview of value-based payment just to set the stage so that we're both kind of thinking the same mental models of what we're talking about, because I don't think it's crystal clear of, a single specific definition of value-based payment. And then I want to talk to you about some of the key capabilities, and that's what we'll spend the most of my time talking about. And then I want to just kind of follow it up to talk about kind of the role of HIT, because a lot of people think, oh, it's just this silver bullet that's going to fix all our problems. And I don't think that's really the case. And then as we think about this transition to value-based payment, what are some of the things that we need to look toward as we're moving forward? So on the next slide, we'll see the way I think about value-based payment is a spectrum. So on the left-hand side here, you kind of have the fee-for-service only model, which is what's kind of dominated our healthcare for the last several decades, if not farther. And all the way on the other side of the spectrum, you have full risk capitation. And a lot of people talk about that as called clinical risk and not actuarial risk. So you could even have on the even farther on the right side, the actuarial risk. But we're not really talking about that. But in the middle, you can have a lot of different ways that you can position it to get you closer to that kind of full capitation or value-based payment model. So, you have what's traditionally been pay for performance or even pay for reporting. You have the ability to bundle payments. So for a particular thing, such as fracture care, you bundle all those things together and you have one payment for that. You also have the ability to have prospective payments with a withhold on performance. So you'll get a percentage up front, and then based on what your quality and cost and utilization measures look like, you can recoup some additional funds. There's also been shared savings, which is called kind of this notion of upside risk. So if there's some savings, you get to share in that with the plan. And then you have adding in the downside risk, you can get to your kind of full capitation. I think what's important from a practice perspective and how that the technology looks at is there's going to be different foci depending on where you're at in the spectrum. So if you're closer to the fee-for-service, what you're worried about or thinking about is encounters and services. How do I improve those? How to make them better? How do I do more of those type of things? If you're in the middle with bundle payment or pay for performance, you're probably going to have special populations you're looking at. So either you're diabetics, that's what your quality measures are at, or if it's fracture care and that's what you're getting your bundle payments on, that's what you focus on. Only until you start to get to shared saving and full risk do you start thinking about kind of your entire population. So I think it's important to think about, depending on where you're at in the spectrum, you may be thinking about only certain populations or you may be thinking about your entire panel. So what I'm going to talk about today in the key capabilities, we're going to talk a lot about kind of that somewhere between that special population and the complete population focus. So if we go on the next slide, CMS has kind of been thinking about this a little bit different, and they have some track that they want to be able to push practices through. And they have these 4 categories. So again, it's kind of that same kind of spectrum where on the left, again, we have this fee-for-service. They see category 2 as adding in some type of quality reporting or pay-for-performance piece. Then when you get to stage 3, they get into their alternative payment models, which is part of the macro legislation of the quality payment program. And then when you get to category 4, then they have those very specific populations by disease or that comprehensive view that we look at. And on the right, you can see that they've been making progress to move practices toward that category 4, and they have plans to do that more moving forward. So to think about value-based payment, it is coming. There are a lot of challenges and issues with data and other things that are going to make it difficult, but I think the horse is out of the barn, and we're going to continue to move toward value-based payment no matter what. So on the next slide, from a practice perspective, then, what is it you need to do? And this eye chart is to make the point that it's not a tweaking of some workflows and adding in different, new check mark boxes in your EHR. This is kind of for many practices, it's a fundamental transformation of their practice and thinking completely differently how they deliver care. This mind map is one that we've been working on at the AAFP as we think about what are all those capabilities. What are those things practices need to have to be able to be successful? So in the next slide, we'll kind of hit on what are the key capabilities that we think they need to be. And these are fairly high level, but I think it gives you an idea of the breadth of things that the practices need to consider. And we're going to go through each of these in a little bit to talk about kind of what are they, to scope them a little bit, and then talk about kind of how do you get this accomplished, with the main focus being, you know, what are the data needs for practices to be able to be successful in this. So in the next slide, we'll kind of combine this notion of risk-stratified care with active care management. You may call this population management. Some people call it panel management, especially if you come from the public health arena, where they think of population more at a community level, where a lot of times in practice and medicine, we talk about population, really talking about a practice or a hospital and the patients that they take care of. So what are we talking about here? We're talking about classifying attributed individuals to different groups based on the likelihood of future cost and health outcomes. And what we're trying to do is identify people as high risk or emerging risk or low risk. You may be wanting to separate them into more categories than those three, but those are the main things that people are thinking about. And finally, you need to establish kind of some unique strategies for each of those groups. So how in a practice you would manage and work with a high-risk patient, say a patient with diabetes, heart disease, high cholesterolemia that is uncontrolled, you're going to treat them a little bit differently, and you're going to need to be more intensive than if you have a 23-year-old with no chronic disease that's in to kind of have their physical and don't have any problems or have a upper respiratory tract infection or something like that. So you have to think about them very differently, because you don't have enough resources to have that high intensity for every patient, and it's really a waste of resources if you try to do that. So on the how, you have to have good data. So the data has to be accurate. So we talked about there what 70% of you said that data accuracy is a problem, and typically thus far we've kind of been putting data into the EHR, thinking about it as being a note, and not thinking of it as being an asset that we would then use to run an analytic and to inform us how we take care of patients or populations. So we're going to have to be better in regards to getting the data more accurate. And I think with use of the data, we can do that. The data has to be timely. If you're trying to do care management and you're getting data 30, 60, 90 days after that it occurs, it's very difficult to make changes in people's lives and changing the care if you're waiting 3 months to be able to do something. The data must be robust and it must be predictive. So if you're not able to use data to determine who's going to be high risk, who's going to have that emerging risk, then you're not able to really do risk-stratified care management and be able to bend the cost curve down significantly. So that core problem with active risk-stratified care management is having really good data to be able to do that. The other big problem is empanelment. So being able to prospectively attribute physicians to patients or patients to physicians. You can do that in kind of a deterministic way or a probabilistic way. So in the deterministic, you have the patient be able to say, who's your primary care physician? Now you can set up incentives in some of the value-based payment models, like some of the folks in California that have had some plans that have 98% of their patients that are actively attributed to a primary care physician. But if you're not able to do that, then you do it in a probabilistic way where you try to look at utilization to try to figure out who's the primary care physician, who's the physician for a particular disease state, and you see how many encounters do they have, how many encounters of a certain type, either it be certain CPT codes or certain ICD-9 codes or 10 codes that are associated, to be able to determine who's the primary care doc, who's the main physician taking care of their diabetes, for example. And that becomes one of the big challenges for being able to have any of that prospective payment that we talk about. But it's also critical to do good risk-stratified care management. You need to know who you're responsible for. And then the other things that you need from a data perspective is you need good risk models. You need very clear and evidence-based care plans. So it's only half the battle to determine who you need to really focus in on. The other question is, how do you be effective in bending the cost and quality curve for them? And last, you need really good task management. So you need to be able to remember who's done what needs to be done for whom, and be able to track that over time. So data is kind of at the forefront of this stratified care management. So on the next slide, we'll kind of move to thinking about that care management from maybe inside of a practice to how do you distribute that across the medical neighborhood. And then that's what we talk about being care coordination. So we're talking about deliberately organizing care and sharing information among everybody that's caring for that patient, and making sure that you have a clear and shared understanding of what the patient wants and what their care plan is, and also what are the roles and responsibilities of individual members of that care team. So to be able to do that, you have to think about, well, who am I coordinating with? So who's seeing my patients? So you may be able to know who you're referring to. And I say maybe because it's probably being recorded in a note, recorded somewhere in the EHR, or maybe in the practice management system, but not in a way that you can pull that out and report on that and look at that and track that over time. But also, since we're not going to go back to the gatekeeper models of the early 90s, patients still have choice on where they go. So even if you're not referring them, they may be going to different places. So being able to have some of that utilization information to know that they were just saw somewhere is going to be important. And then also you need to know whom your patients are seeing, what's the quality, what's the cost. How do you help patients understand where to direct them across the community of subspecialists and hospitals based on the needs of the patient. So being able to have that cost and quality is going to be important. And then, of course, since we're sharing information, interoperability is critical. And we need to be able to have patient health data to be able to be sent around. We need to have that utilization information be able to send around. And we need to have a shared care plan so everybody kind of is on the same page regarding what we want to do for this patient now and into the near future. We also need to think through kind of a more robust communication between the team members. Right now, typically, I send the referral and you go see them and then they send me a note back. I think as we continue to move forward and think very differently and have the ability for virtual care, that having more of a team-based approach where we're having more constant communication is going to be important. So in those cases, how do you manage the data needs around that communication? And again, just like with the active care management, the task management and tracking is also critical. But now you have this across multiple organizations, across multiple EHR vendors. So how do you able to manage that? So the data issues here are a little bit more daunting than on the stratified care management. On the next slide, we'll move to the next core component, which is patient engagement. And here it's talking about empowering patients to take an active role in their care to improve their health and to lower their costs. A lot of that deals with patient education and providing them access to their health record. And to be more advanced, some practices are working on capabilities to have self-management and self-service for the patient. So in the how, this right now I think is a lot about talking about the technology. I tried not to do that in this presentation and when I talk about things, but this is right now is really geared a lot into what's the technology that you have at your disposal as a practice. The patient portal is probably the number one modality physicians or practices are using right now, but there is this notion of open APIs. So being able to have access to the data and not have to go to a portal. So with meaningful use, we kind of started to have a trend toward tethering the PHR and the portal to the physician's EHR. And with open APIs, we start to be able to break that tether. So now as a patient, instead of having maybe 3 or 4 portals with your different physicians you see, you have the ability to have a portal that's really designed for you that has access to the data and those 4 other EHRs and can pull that data together. So you have all those data issues around how do you make sure those APIs work and you pull that together. And now you also have all those semantic problems that you guys alluded to in the poll too, of how do you start to stitch that together and not just stitch it together in a longitudinal fashion saying, oh, well, I got this piece of data, then I got that piece of data. But no, what is the medication list? What's the current medication list across those 4 different EHRs? Physicians have a process to how do you educate the patient on these things because it's still, I think, a learning curve for patients on what the real value of this. I think secure messaging fits into that. And then we have this notion of remote patient monitoring, which opens up a whole kind of can of worms around patient-generated health data. So How does that data get integrated into the record? How does that become part of the decision support potentially inside of an EHR? So that remote patient monitoring and patient-related health data, I think, will be another data issue that we'll have to deal with. And lastly here, too, we need to make sure that we have a shared care planning and decision-making, so the patient is actually part of that process and helping make the decisions around the care plan. So on the next slide, we get to the notions of access and continuity. So this is really from a primary care perspective, being the point of entry into the healthcare system. So whenever you need any type of healthcare, you don't have to worry about who do I talk to or what do I really need. You have this point of entry that can help you navigate where you need to go. So that needs to be 24/7 available. There's a lot of potential now for virtual care and telemedicine capabilities. There's also this notion of open access scheduling. So just because you're open, but if you have to wait 6 months to get an appointment, that doesn't really make things accessible. So this notion of open access scheduling, so you can have kind of same-day appointment types of things for people that need it. And then finally, the notion of the patient's data flows with them across the healthcare system. So wherever they go to need care, that their data is able to flow with them. So how that's done a lot of time in practice is looking at extended hours and on-call providers, relationships with after-hours clinics and providers. So this is where the data starts to get into being an issue. How do you give access to the patient's records in a way that makes sense? And if it's an after-hours, do you want them actually as an access to your EHR, or do you want them to be able to access a summary of care? Are they able to do queries against your system? So as we're thinking about having that extension without having to keep your own clinic open, how do you make sure that the patient's data flows appropriately? Maybe that's through a health information exchange. Unfortunately, not everybody can participate in one. There's not one for in every location. But any of these things, of course, the transition of care is the key component. And it's something that we've been working on for at least a decade or so, and I would still say that we've not done a good job of making sure that even just a summary of care can move with the patient, let alone their entire record. So on to the next slide. So the last one I want to talk a little bit about is performance improvement. And I call it performance improvement instead of quality improvement because I think there's really a difference between quality and performance. So on a quality perspective, it's really about the patient and their health and their well-being. And it doesn't matter what the physician has done or not done, or they had access to them, that they didn't come to see me as a provider, so I shouldn't get dinged because the patient didn't come to me. All that stuff is, in my view, doesn't make any sense when you're thinking about quality. But when you're thinking about performance, then you can start thinking about some of those things like, how well did I do relative to making sure that those patients got the best possible care and then the best possible optimized health that they could. So in that case, you need to measure both the notion of the health of those folks, but then also who is impaneled onto you, and finally, what is the performance that you took to achieve those health outcomes. You need to make sure that you're taking appropriate actions to make systemic change in the practice. So there you have this notion of this plan, do, study, act cycles where you're doing this kind of continual improvement inside your practice. You need to have metrics over time to make sure that you're doing that in a timely manner. So again, on this notion of quality improvement, performance improvement, you need to have really good data. It needs to be, again, accurate and timely. It also has to be semantically unambiguous. Otherwise, you get to this point where you're having the end users do a bunch of checkmark boxes so that you can create your quality measures or your performance measures. But rather, if you actually had the system set up that was semantically rich, the system could make some of those determinations and not require the check marking of the boxes by the providers. You need to be able to have a dashboard to be able to monitor the progress and triage your measurement. So where are the things that you're doing well and what are the things you're not doing well on, and how can you focus on those things that you're not doing well on. You need to have a robust set of analytics to be able to calculate the measures. you need to be able to drill down. So once you have this population say, we're not doing well on this particular measure, well, what are those patients that we're not doing well on? Now, can I take one of those particular patients and say, why for this particular patient are we not meeting the quality measure for them? And finally, you need to be able to have access to data that's outside the practice, such as utilization data, lab data, med adherence data as examples. For a lot of things, especially in a primary care arena, you may want to make sure those things are done, but you may not actually fulfill those. So you may not be doing the mammogram or the colonoscopy or the retinal exam for the diabetic. So you need to be able to track that utilization outside of the practice. So you need that data. So those are some of the key capabilities I think you need as a practice to be able to be successful in value-based payment. And what are some of those data issues relative to that? On the next slide, we'll kind of try to make this transition and think about what's the kind of the role of the health information technology. And first and foremost, though, I want to talk a little bit about what's called a work system. So the technology is only a single piece. So you take those tools and technology, you take the people that have the skill sets that they have, you take the tasks that they need to do, you put them inside that physical environment that they have to be able to do those tasks, and then you have the organizational structure that surrounds that physical space, and then you have the external environment. That entire thing is what industrial systems engineering calls a work system. It is only that work system then that goes through a process to get to the outcomes. If you just focus on one of those things, such as just focus on the technology, you're doing what's called local optimization and kind of lean and industrial engineering language. And we know that local optimization doesn't get you system level optimization. So I'm going to talk a little bit more about kind of the role of health IT, but I want you to understand that if you're thinking about doing change and significant improvements, you need to think about the entire work system and what are the roles and pieces of each of those, and not just focus on the technology. On the next slide. So as a role for kind of health IT and specifically, I think the success is really on the data and interoperability, and we know that health IT is the core piece that's going to help us get to that access to that data and get that interoperability. I think we need to really focus on automating the care delivery now. It's much more important than billing and documentation. We spend a lot of time building technology to support that billing and documentation. I would say too, though, that we need to make sure that we don't replicate that same type of problem of not having the right focus. And we should not be focusing just on the care delivery, but rather we should be thinking about what's the health of the population and the patients, and then what's the care that we need. And finally, I think value-based payment is going to completely change the value generation for both EHRs and healthcare providers. So there's a lot of ambiguity and uncertainty now on where's the value of these systems and these practices moving forward. And I think that's going to make it a little bit more challenging for change in this environment. Next slide. So the last piece of context that I want to talk about is kind of, so we talked about all this value-based payment, we talked about all these key capabilities, we talked about the role of the technology, but what's the practice look like that we're trying to deploy that stuff into? And unfortunately, right now, there's a high level of physician burnout. In 2014, over 50% of physicians had at least one symptom of burnout. And unfortunately, there's some real dire consequences of that. And on the personal side, depression, suicide. And on the professional side, we have errors, we have decreased productivity, and we have physician burnout. So on the next slide, we'll kind of dig into what are some of the reasons for the burnout. And a lot of that has to do with the work pace they have, the chaos, the control that they have. And I think there's a real potential for value-based payment to drive more of the time pace issues. It definitely has the potential to add more chaos into a practice. And physicians may be getting less control of how they work and when they work. So as we do this, I have this concern that we have the potential to even exacerbate the physician burnout piece that we have. So I think we need to really focus on making sure as we implementing value-based payment and the data issues relative to that that we think about this kind of physician burnout. Because if you look at this, you know, the EHR and bureaucratic tasks, and those things are all things that are leading to, or excuse me, contributing toward burnout today. Now, next slide. So looking forward, you know, like I said, value-based payment is coming. We need health IT and work systems that really enable us to deliver value-based care. We need to be careful, again, because of the issues around burnout. Being data-driven is more critical than ever. I don't think you can be successful anymore if you're not data-driven as a practice and as a hospital. Really the North Star here needs to be that optimized health. Again, don't let us fall short again, like you did with focusing on billing and documentation. Let's not focus on as much care as we are focusing on that optimum health. And the quadruple aim, which is lower cost, better quality, better patient experience, and better provider and staff satisfaction should be the measure of success for us. And lastly, and deals really with the data, measuring value, the quality measures and attribution, all that kind of stuff is not going to be easy. So as we think about the practices of the future with value-based payment, I think there's a lot of the things inside the practices that will be the same, but we're going to really have to redesign the function and use of those moving forward. So I think it's kind of akin to the top picture here is the inside of a computer, a desktop computer. The lower one is the inside of an iPad. They both have, you know, CPUs, RAM, buses, hard drives, screen, but how they're put together is vastly different, which allows for a completely different use of the technology. And I think that's what we need to think about as we're moving toward value-based payment and what health IT and data can do for that. So I appreciate you taking the time. Look forward to any questions that we have.
Thank you so much, Dr. Waldron. That was chock full of information and very informative. We really appreciate you taking the time with us today. While you've been speaking, we have had a couple questions come in, and they're both for you, Dr. Waldron. So the first question, and I'm going to kind of paraphrase a little bit, but in this world of telemedicine, do you anticipate any unique challenges in this transition from fee-for-service to value-based payment, value-based care in the telemedicine specifically?
Yeah, and I think it's going to be a double-edged sword as it relates to value-based payment, that being telemedicine. So on one side, I think there's really an opportunity to lever telemedicine to lower the cost, I mean, it can reduce the price as well, but the cost of, actually, what's the cost of practice to take care of a patient? Doing it from a telemedicine perspective has an opportunity to lower that cost. I think it also has an opportunity to increase the touch of a practice. So instead of seeing your diabetics quarterly, because all you have is the ability to have them come in to see you in the office, and that's as much time as you have, can you have maybe a monthly connection with them, with a care coordinator or with you quickly via telemedicine? So I think those things are ways that value-based payment will really drive it. I think there's also an opportunity from a telemedicine perspective on the direct-to-consumer piece to really get to that issue of continuity and the challenges relative to that. So I think that's really the potential downside. But I don't think we're going to put telemedicine back in the bottle, and we're not going to put direct-to-consumer telemedicine back in the bottle either. So as a practice, we need to compete well and continue to add the value to it so that we can continue to incorporate that into our practices as we move forward.
That makes sense, Dr. Waldron. And the second question revolves around this idea of the confidence in the data. So one of the questions is, what recommendations do you have on building the confidence level in the data being presented to clinicians? And there were several questions that were kind of in that same vein of how do we make sure that we trust our own data and even the data we're exchanging with other stakeholders?
Yeah, and I think those are they're the same kind of issue, but they're a little bit too different. So on the exchange, as you have this notion of provenance, So how do I know that that data actually came from the place that it says it came from, and that it was not, changed from when it was originally created by that organization? And then how do I make sure that they actually had good data quality processes in place so that they were likely to put in accurate data to begin with? And I think that the Provenance piece is one that we're kind of struggling with today. I think we've done a good job on everything except kind of that source level that we have to kind of work on. And as we add patient-generated health data, I think that's going to be more and more of a concern. But the other piece, I think, is one that is more interesting, and that's how do I trust the data that's in my system? And typically, we've seen that a lot on kind of the quality measurement. So as you present quality measures to physicians, if they're doing well, they're probably not going to question the data. If they're not doing well, they're going to question the data. So I think you have to have a process that once they question the data, said, okay, that might be an issue. I'll tell you what, this is what we've done to ensure the quality and accuracy of this information, but let's go in and start digging in and looking at that. And what I've seen in talking with several of our members that have went through this process, for them, once they go through a couple of the measures and realize that, yep, it's their data, it is accurate data, and they were just not doing well, and when they go to individual patients, they say, oh, well, Ms. Smith, I remember her husband just died when she came in, so we talked a lot about that, but you know what, I didn't do these 2 things that I should have done for her. And then she came back, and then she had a sprained ankle, so I was doing that, so I didn't. So then they realized that, oh, there's this systematic kind of problem. So I think those are the things you need to do. 1, show the data to the doc. You got to use the data if you want to be able to improve it. 2, you need to show them what you've done, that you've taken seriously data quality issues. And thirdly, you just have to dig into the data and demonstrate to them that it actually is good data. And I think that will start to change the minds of the physicians.
Thank you for that answer. That was very comprehensive. The next question is for CAQH Core, and the question is, what are we considering beyond HIPAA for value-based care, value-based payments, and what is the time frame?
Thanks, Jessica. And this is Erin Weber speaking. There are really 4 areas that came up in the research that we have initially started. The first is data quality improvement and standardization. The second is provider-patient attribution, then patient risk stratification, and then lastly, infrastructure interoperability and best practices around that. So from a time frame perspective, we will be looking to release our initial report early next year, followed by the formation of an action group, which will look at the specific recommendations and opportunities within each of these areas to identify how they should be prioritized and where the greatest ROI is, and what is meaningful to do now versus when we're a little bit farther down the path with VBP. So that group will be kind of making those decisions and providing guidance over next year. And then hopefully we'll be rolling out some more focused teams looking at each individual issue later next year. I think one of the interesting components of this work is that depending on the topic, depends on who within the industry and each organization needs to be involved in the effort. So if any of these areas are of interest to folks on the line, we do encourage you to reach out to us and get involved.
Thank you, Erin. The next question is for Dr. Waldron. So what do we say to our non-EHR providers who want to implement VBP? What should they do next or first?
Yeah, and I think that's an interesting question. I mean, I think the adoption of EHR has been rather high. I don't think you need an EHR, but you need some type of technology to be able to support this. Otherwise, I think the administrative task is too great to be able to do it, especially when we look at you're going to have likely have multiple payers. So you have to have a system that can be able to support doing this more than one time. So you're going to need to have some type of technology. You might be, if you're a smaller practice and you have really focused and you're still on the earlier side of the spectrum of paper performance, may be able to create some Excel spreadsheets to be able to start tracking the data that you want and that you need and be able to manage that. But I think you need to start thinking about what are the technology things that I need to be able to do to capture the data, analyze the data, and report the data. You may not need an EHR from the standpoint of doing all your documentation and your notes, but I think you're going to have some type of technology to be able to manage this. Otherwise, it's just going to be too unwieldy.
Thank you, Dr. Waldron. So let's see. The next question, I'm trying to think about how to paraphrase. Oh, so the next question, I'm not sure if it's for Dr. Waldron or for CAQH Core, but the question is, how do we envision the improvement in interoperability to promote BVP systems when most of the physicians are using open source EMRs rather than certified EHRs? Do we have any thoughts on that?
This is Steve. So I don't think a lot of docs are using open source. Most docs are using closed source or proprietary systems. But I think, regardless, I think there still has a requirement to have a set of standards, data standards, transport standards, trust standards, to be able to do the exchange of the information, regardless of the system, if it's certified or it's not certified. Because we know with certification, that doesn't necessarily mean that two things that are certified to be interoperable, out in the wild, that actually are interoperable. So I don't know that I have this, nice, silver bullet for this problem, but I think it is those sets of standards and then some type of adherence, either it be that the business, healthcare community sets incentives that you can't be in business if you're not using these standards, or that we use the heavy hand of government, to mandate their use and to enforce them. The Office of the Inspector General, because of the 21st Century Cures, is going to put together an enforcement package for information blocking. So one would be do we think that once these standards are in place, if you're not using them, is that considered information blocking? And we'll just have to wait and see what they think at OIG.
Thank you. And then this is the last question, and I think it's for Erin. Is anyone looking at standards for defining BVP measures, as this would simplify things for providers?
Thanks, Jessica. And this definitely did come up in our research from a couple different angles. One of the opportunities I mentioned was data quality improvement and looking at common data sets and common data definitions, because health plans are defining these differently. So coming together and creating some definitions around this, I think, would help to improve the experience for providers. From a quality measure perspective, we certainly did hear also the need for fewer quality measures, and I know there are several in the industry working in this area as well.
Thank you so much. And we are out of time for today. I would like to thank our speakers, especially our featured speaker, Dr. Stephen Waldron, for joining us today. On this next slide are the next several webinars we have scheduled. Please register, as we have some good contact in the next few months. And in the next slide, as a reminder, links to the webinar slides and recording will be available for download tomorrow. We'll also send both of those to you via email. Thank you again, and please keep in touch with us. You can see our website and our email on the screen. Have a good afternoon.
Take care.